In this module, we will show some examples of MEG analysis in basic research and in established clinical applications. In this module, you will be introduced to a few MEG examples, pointing out the unique advantages to magnetometers versus gradiometers. In addition, you will learn how MEG can be used to map cortical activation sequences and how MEG is used in clinical settings. MEG's triple sensor array combines two kinds of sensors: magnetometers and planar gradiometers. They are manufactured with thin film technology and occupy physically the same space. However, a magnetometer and a planar gradiometer have very different sensitivity patterns. Overlaying a magnetometer and two planar gradiometers in the same sensor unit conveys more information about the brain activity than using either of the sensor types alone. Here we can see an example of auditory evoked responses in magnetometers and gradiometers. The largest deflections are highlighted and the source currents in the brain are shown schematically by green arrows. Magnetometer signals exhibit two maxima with opposite signs, somewhat off the active brain region, while the planar gradiometer signals show a single peak on top of the source. Hence, the magnetometer and gradiometer signals require different interpretations. In the following, we will show some examples of MEG research studies. The first example presents a study where the broad sensitivity pattern of magnetometers was utilized to analyze very weak sources located deep in the brain. Brainstem auditory evoked fields, BAEFs, provide diagnostic value in pathologies involving the early parts of the auditory pathway. Here, the subject was measured for 30 minutes while receiving auditory click stimuli, yielding about 16,000 epochs to average. The signals were bandpass filtered to the frequency band 180 to 1000 Hz prior to averaging. Corresponding electric brainstem evoked potentials, BAEP, were recorded simultaneously and averaged to confirm the timing of the response peaks. Only magnetometer channels were used in the analysis because gradiometer channels cannot resolve signals from such weak sources located far away from the sensors. Even after signal averaging, the brainstem evoked fields are very weak. The peak amplitudes of about 5 femtotesla are probably the weakest detectable biomagnetic signals. Equivalent current dipole modeling was applied to localize the neuronal generators at 4 identified earliest peak times. The dipole locations of the earliest observed deflections, best fit at 2.3 milliseconds, indicated a contribution from the auditory nerve, with an extremely weak dipole amplitude of less than 1 nanoampere. The next dipole, at 3.1 milliseconds, was localized near the ipsilateral cochlear nucleus. The location at 5.7 milliseconds was contralateral, near but lateral and posterior to the lateral lemniscus. The earliest detected cortical response peaked at about 11 milliseconds. In summary, the magnetic counterparts of the electric brainstem evoked potentials can be measured in 30 minutes, and they allow localization of some of the underlying neural sources in individual subjects. The second research example demonstrates the unique spatial resolution capability of planar gradiometers in a mirrored neuron study. Planar gradiometers have a very focal sensitivity pattern, which makes them sensitive to sources directly underneath the sensor and almost blind to other interfering sources in the brain and outside of the sensor array. Viewing another person's actions automatically activates brain areas belonging to the mirror neuron system, assumed to link action, execution, and observation. In this MEG study, the subjects were shown frozen orofacial gestures. Their task was either to observe the picture passively or to imitate the gesture in the picture. Landscape scenes were displayed as neutral control stimuli. Evoked responses in each category were averaged and analyzed. The analysis of the cortical network was performed by visual identification of the latencies of peak responses at the gradiometer channels. Because planar gradiometers are sensitive mainly to cortical sources laying directly underneath, we can name the analysis as hardware beamforming. In the imitation condition, the earliest signals peaked at 110 to 120 milliseconds at the posterior location, and the peak latencies increased systematically from location A to locations B, C, D, and E. Such a sequence corresponds to the progression of activation from the occipital visual areas to the superior temporal sulcus, then to the inferior parietal areas, then to Broca's region in the inferior frontal cortex, and finally to the primary motor cortex. In the observation condition, the sequence of activation was very similar to the imitation. Viewing the control stimuli resulted in activations of areas A to C only, indicating clear stimulus specificity of the underlying neural circuits. The signals of Broca's area and the motor cortex were significantly stronger during imitation than in other conditions. The results demonstrate that still pictures only implying motion activate the human mirror neuron system in a well-defined temporal order. This network was identified only by observing the peak latencies of gradiometer signals without specific source imaging. Currently established clinical applications of MEG include pre-surgical functional mapping and epilepsy analysis. Tumors, vascular malformations, and previous operations may deform brain anatomy so that it is impossible to identify, for example, primary motor cortex from preoperative magnetic resonance images or from anatomic landmarks during surgery. Source locations of MEG signals displayed on three-dimensional MR images, including the blood vessels on the brain surface, aid in pinpointing functionally irretrievable areas before and during neurosurgery. In this case, functional mapping was performed on a patient with a grade 2 glioma. MEG source localizations of various responses are displayed on the surface of a preoperative 3D rendering of the brain. Purple, median nerve SEFs from hand S1. Red, tibial nerve SEFs from foot S1. Yellow, lip SEFs from lip S1. White, AEFs from auditory cortex. The corresponding brain surface image during the surgery indicates that the veins are readily identifiable and allow both the localization of the somatosensory cortex left and the tumor area right below. Vein bifurcation over the tumor is marked with an arrow. The same study was performed after the surgery, and corresponding source localizations displayed on a postoperative 3D rendering surface along with blue, foot MEFs from M1, and green, hand MEFs from M1 indicate that the surgery did successfully avoid any damage to the somatosensory cortex. In addition to pre-surgical functional mapping of visual, auditory, somatosensory, and motor cortex in the brain, MEG is also used to non-invasively locate regions of epileptic activity within the brain. Surgical resection is an effective treatment for patients with intractable epilepsy, especially children. The localization information provided by MEG may be used in conjunction with other diagnostic data in neurosurgical planning. This example shows a single interictal epileptiform discharge spike signal and spatial map pattern on the left, and equivalent dipole localizations from similar spikes superimposed on the patient's MRI on the right. MEG appears to be particularly beneficial in the study of patients with non-lesional neocortical epilepsy and in patients with large lesions where it may provide unique information on the epileptogenic zone in relation to the lesion. Sources of epileptic spikes can be integrated into neuronavigation systems. It has been shown that MEG provides non-redundant information in 33% of patients and adds useful information that changes and improves treatment, thus providing clinical benefits in patients who undergo surgery. In addition, MEG and EEG in combination detect more interictal discharges compared to EEG alone. An extensive search for new ways to use MEG in clinics is underway. Most promising approaches include detection of plastic changes elicited by different types of brain or peripheral nervous system pathology, modification of spontaneous MEG signals detected by various signal analysis methods in patients with stroke, head trauma, or degenerative brain diseases may also provide clinically useful information in the future. The emerging applications are highly exciting and will provide new opportunities for MEG studies in clinical settings for language lateralization, traumatic brain injury, post-traumatic stress disorder, Alzheimer's disease, and autism. The manuals that come with your MEG system contain important information about using your MEG, including safety warnings. You must familiarize yourself with this material before operating your MEG.